So in chapter 14, we're going to be talking about health technology assessment. There are two parts to health technology assessment: cost effectiveness analysis, which is the science of measuring and comparing the costs and benefits of medical treatments. And then there's cost benefit analysis, which is a process of choosing the optimal treatment by trading off between money and health. Health technology assessment is pretty controversial because it involves placing a dollar value on human life and on health. So we're going to start with cost effectiveness analysis. And so this is the process of measuring the costs and benefits of health care, like medical treatments, procedures, and therapies. It's the less controversial portion because it's just concerned with measuring those costs and benefits, not necessarily balancing them against each other to make an optimal choice. With cost effectiveness analysis, there's often multiple kinds of treatments that you could choose from to treat any particular disease. Let's say different kinds of drugs that you can take for, a particular sickness. And so insurance companies have to decide which treatment they're going to cover. And patients sometimes have to decide between perhaps a really expensive but very effective treatment route versus a low-cost treatment that might be less effective. If one treatment is cheaper and more effective, it's just like it costs less and is better, then there's really no question. You're just going to choose that one. That means the other one has been dominated. So it's never a good idea. It's never optimal to use the dominated treatment when there's like this more effective, cheaper alternative available. If neither treatment is dominant, that means that one of the treatments is both more expensive and more effective, and that's when you're going to use cost effectiveness analysis to help you try to think about whether or not it's worth it. So the way you implement it in practice is the incremental cost effectiveness ratio, or ICER. It's actually pretty widely used by a lot of health departments, definitely the National Health Service in the UK, when the government is deciding what their public coverage is going to pay for. But the way it works, let's say there's two treatments for a particular disease, A and B. One of them is more expensive and more effective than B. And so neither treatment is wholly dominated. We'll have a more concrete example in just a second. But essentially, the ICER is just the difference in the cost divided by the difference in the outcomes in the benefits. And it's going to be greater than zero. So it's going to be greater than zero because neither of them is wholly dominated over the other. So for the example, let's say that there are two different ways you can treat lead poisoning. One is a more aggressive treatment and it costs more, but it reduces your probability of developing a reading disability. So the aggressive treatment, which is more expensive, has a lower probability of developing that reading disability. And so when you're comparing how the incremental cost effectiveness of the more aggressive treatment over the more conservative treatment, you do the difference in the price over the difference in the outcomes, which is here the probability of the reading disability. And essentially it's like $7,241 to avoid a reading disability. And if that is worth it, then you spring for the more expensive treatment. So the ICER doesn't exactly tell you whether or not it's worth it. It just gives you an empirical fact about these costs. There's also the average cost effectiveness ratio, where it's just the cost over the outcome, where you're not comparing two different things. But the thing is, you might think like, oh, why not just do that for each of the treatments and see which one is the lowest cost per additional, let's say, year of life or, reading disability reduction. But the thing is that the average cost effectiveness ratio, it does tell you which one is the cheapest way of doing it, but it doesn't necessarily point out that some of them are a little bit more expensive, but they also might be more effective in practice. So just because something is cheaper per life year doesn't necessarily mean it's the most effective or even the most cost-effective route. So we have the ACER, we also have the ICER, and the ICER is kind of used more frequently in practice.